Hey, my name is Philip Melo, and today we are going to discuss what actually we learned from COVID-19. And I also would like to discuss with you how we can estimate parameters that affect, let's say, mortality in COVID-19 because it's a common, let's say, mistake not to correctly estimate parameters. And I would like just to discuss with you how actually we need to estimate parameters and estimate risk we are working with COVID-19. Let me just share with you my screen and okay, just do that. All right, so today our lecture is Public Health, Informatics, and Technology. We talk at the first part of lecture, what did we learn from the COVID-19 pandemic, and then how to evaluate the population's health. So first of all, the population health, we already discussed this in my previous lectures, is different from public health because population health focuses on the health status and health outcomes within a specific group of people. But the public health focuses on a larger groups of people, can be state, can be countries, and so forth, can be different, let's say, groups of professions and whatever. But population health is limited to health status and health outcomes to specific groups of people. So this is a difference between population and public health. And today we are going to talk about population health also. So first of all, I would like just to remind you what does mean epidemic. Epidemic is a rapid spread of a disease through a population in a relatively short time. So it's like a splash, like an epidemic is just a burst. It is a rapid spread of a disease through a population in a relatively short time. An example of that, it is we have 2014 West Africa Ebola epidemic. You see that how it is spike of that, and then it goes down like a bell shape. Okay, that is epidemic. Outbreak is a little bit generalized general term, and outbreak when there are more disease cases than when is usually expected for a given time or within a specific location or for a target population. So this is an outbreak. And actually we deal mostly with outbreaks because pandemic is also an outbreak. So a pandemic is an outbreak of infectious disease that occurs over a wide geographical area and that is of high prevalence, generally affecting a significant proportion of the world population. International data available also in when it is pandemic. So pandemic and epidemic. So pandemics arise from epidemics, actually. This is a chart. This is kind of a good explanation. What does it mean? Endemic. Endemic is constantly present in the population. It can go for many years in a population or region with relatively low spread. So it doesn't spread fast. Endemic. Epidemic is a sudden increase in cases, as we discussed in terms of Ebola. And the pandemic, it is sudden increase in cases across several countries, continent, or even the world. So it is a very widespread, and it is a sudden increase with high velocity of spread. So this is what happens. So today we're going to talk about how we can also evaluate population health using data from COVID-19, which is a pandemic. Here is just, I'll skip my slides here because it is just reminds us what pandemics we had lately. So we had Russian flu, then we had Spanish flu that caused over 50 million. Some experts believe that it's up to 100 million deaths we had. And we had Asian flu, we have 7 cholera, we had AIDS, HIV in 1981 that had 30 million people worldwide who died. Then we had 2003, we had MERS, we had Ebola, we had Zika, and finally 2019-20, we have COVID-19. And like SARS and MERS, this is caused by a coronavirus dubbed SARS-CoV-2. But this one got away from us, perhaps due to traits such as its ability to spread from people with mild or no symptoms. So this is very interesting in terms of research and analysis. So we had 780 million COVID-19 infections and over 7 million deaths. Okay, so this is what COVID-19. At COVID-19, this is an example how COVID-19 spreads in terms of infection from, let's say, March 20, it is just February, goes to 2023. So this is, we had a second wave, and we will talk about the prediction. We will also discuss in my future lectures how to build prediction modeling, and we will try to model this second wave. So this will be very interesting. But today we're talking about something else. So major risks of COVID-19, and when we talk about in data science about COVID-19, we need to identify some parameters that affect, let's say, mortality and morbidity. And some of them I just listed here. It is chronic lung diseases, diabetes, heart conditions, immunocompromised state like HIV, AIDS, liver disease, overweight and obesity, pregnancy, smoking, stroke, substance use disorders such as alcohol, opioid, or cocaine use disorders, tuberculosis, and etc. And it's very, very, very interesting, very important from the point of view of public health informatics and technology is to identify the impact of these parameters on the mortality and morbidity. So what is major challenges in COVID-19 fit? And what we found out that actually we were not actually ready to give an adequate answer to COVID-19 monitoring and spread and prediction of its spread because of this. I just listed 6 major drawbacks. The first drawback, it is slow data exchange. Okay, then we have inability to use multi-stream real-time big data because actually our algorithms in data science and data analytics focused on static data. And static data we found out in COVID-19 were not good, were not adequate compared to the challenges that COVID-19 offered. So inability to use multi-stream real-time big data was a big drawback in facing the challenges and responding correctly on its challenges in the countries, in the different areas, and even worldwide. So we have this is inability to use real-time big data, working with big data. It causes also annually like billions of dollars in losses, not in the US, but also in other countries in the world. And big data is a very important topic, and we already discussed some of these possibilities, how to work with big data, and we found out that it's not something extraordinarily difficult. So then we have in COVID-19 showed that we didn't have efficient algorithms, including, let's say, predictive modeling. So we could not predict adequately the spread of disease, the second wave, and so forth. Then we had poor data integration. And this is quite natural because in public health, we know that data coming from different sources. So, and the sources are different, and not in terms of sources themselves, but also the data coming in different structures, in different formats, in different types, and so forth, and even in different velocities. we actually could not explore in COVID-19 the whole wealth of important information of electronic health records. And we had very limited use of machine learning, data mining, artificial intelligence for decision support. So we didn't didn't exploit all this machinery, didn't leverage all this very powerful machinery in working with COVID data. And this, of course, was not what was a stumbling block for on the route to gaining information from COVID-19 data. And of course, we have the second one, the sixth one is a lack of accurate estimation of risks. And today we are going to talk about this, how to correctly estimate risk, because there is some kind of, it is a common mistake in estimation of risk. So today we are going to talk about this. All right. So first of all, I would like to say that when we have, let's say, mortality, we say, for example, it depends on population, on obesity, and other parameters here. Okay, that is what we just listed before. And when we have two parameters, it is very simple because these variations of mortality we can present in terms of partial derivatives. And when we have just two parameters, it's very easy. And suppose they are independent. Okay, so that's what we do. And however, when we have some parameters which are also depend on these parameters. So for example, we have obesity, and this is age. So age also is related to obesity because many people in age, for example, over 65, they have a larger number of obese people. So obesity comes with age. And when we just put it is here age, sometimes we forgot about it and we make a mistake. So actually, when we do partial derivatives, we have this is obesity, and this is also age that depends on obesity. And this is other parameters, for example. So what happens is that actually what we measure this one, effect of obesity on the mortality, but also obesity comes with age because age also gives contribution of obesity. And when we just do this, we overestimate this obesity. We say that it can go to 4 and even more in terms of 4 times more obese people die. But we forgot that we need to subtract this one because we are interested in obesity only, but also this contribute this term, which also is age depends on obesity, which is not 0. Here also can be different parameters, like, for example, diabetes and so forth. So all these risks, as I just presented a slide before, we need to carefully and accurately estimate, correctly estimate. So we call it this multivariate analysis. And multivariate analysis is exactly what we need to use when we work with COVID-19 and other pandemics to identify risks. Okay, this is where you have to use multivariate analysis to do accurately and correctly estimate. Otherwise, we will make our estimates not correctly. So let us see now. This is an example of COVID-19 mortality rates, obese, non-obese. We had, for instance, we had in 1,000 people, 26 death mortality, obese 19, and out of 400, and 7 non-obese out of 600. Okay, so what we do here, it is very easy to calculate the ratio between the obesity and non-obese patients. So we can just need to divide 19 over 400. This is the ratio of obesity, and this is not obesity, so normal rate. And we can have this 0.475, and this is 0.012. So when we divide this by that, it gives you a ratio obesity over not obesity. It is 4.1. And this is what actually 4.1 is. Actually, it is this one, this term, because age also, we forgot about age. And we now have to make corrections. Okay, let us do now. So to do corrections, we have another statistics that we took from the COVID-19 data, and we found that age 65 out of 500 people, we had 390 obese, and age less than 65, we had 110 in average, so over 500. So for that, we also do these calculations because we had these people who are over 65, 21 died, and 479 survived out of 500. And less than 65, it is 5 died out of 500, and 495 survived. So we have 26 deaths. That's what we had here, 26 deaths. All right. So what we do, we call this stratified analysis. In stratified analysis, we just take, let's say, the age less than 65. We had only one person died out of 90, and 4 died out of 410. So altogether it is 500. And when we look at this age over 65, we have different statistics. We have 18 people died out of 390, and 3 people not obese with normal weight out of only 110. Okay, so these statistics, and we found that the risk ratio, actually, if we consider this risk ratio for people 65, we had 1.7. So we have to make a correction now, and we use, for example, actually to do these calculations with many parameters, and so we can use the so-called Cochrane-Mantel-Hansel method for evaluation confounding. And we see here that actually this age plays an important role. It gives you 1.7. So we need to now make correction to this because otherwise you will estimate this actually as 4, but this one gives you, these terms gives you impact, and this impact is of course important. 1.7, we need to subtract the impact of the age and obesity. Okay, so this is important, and there are some people, they make mistakes, and then it is a common mistake. So they just do it without analyzing, without doing multivariate analysis to understand what other parameters contribute to the let's say mortality, morbidity, because there are confounding. We call it as confounding, and this one, the relationship between obesity and mortality by COVID-19 was confounded by age. So age plays important role. You remember, it gives 1.7, and this is important role. When all the data was pulled, it appeared that the risk ratio for the association between obesity and mortality was 4.1 actually. However, when we stratified the analysis into those age less than 65 and those age 65 plus, we saw that for 65 plus group had a risk ratio of about 1.7. The distortion was due to the fact that obese individuals tended to be older. Okay, so this one is important, and older age is an independent risk factor for mortality. Consequently, in the analysis using the combined data set, risk factor 4.1, the obese group had the added burden of an additional risk factor. So because in this 4.1, there is also hidden an additional risk factor, so we need to subtract. Okay, so we have a special algorithm that does multivariate analysis, and if you do everything correct, you can just do a very interesting work. I would like to show you something. Okay, so that is confounding occurs when the prime parameter obesity is mixed up with some other factor, for example, age. So we use multivariate analysis to forecast disease spread and outcomes based on multiple health and environmental variables. So we need to take these advantages. I just showed you now as an example, but when of course we work with more difficult, let's say, problems, when we have various confounding terms, and when you do right, you can see that there is some distortions, some things that you should take into account. Otherwise, your results won't be correct. So age, older adults are at higher risk of getting very sick from COVID-19. More than 81% of COVID-19 deaths occur in people over age 65. That's what we found out also. And the number of deaths among people over age 65 is 97 times higher than among people age 18 to 29. And we take care of this data, and we do multivariate analysis for each parameter to see if there are confounding in the data. And if it is confounding the data, our algorithms makes correction on confounding terms, and we have correct estimates of risks. That is important. And what is very interesting that when you take all these kind of terms, all these kind of parameters that affect morbidity and mortality, that we can come up and introduce the so-called public health index. So public health index, the higher public health index, the bigger resistance of public health to pandemics. For example, on the example of COVID-19, and in terms of Hawaii, we have 86.4%. It is quite high resistance. So in case of, let's say, things, the pandemics similar to COVID-19, which give us similar data, population in Hawaii won't be so affected as other, for example, groups of other populations. There is a Vermont. Vermont is 81.2. It is also quite high. And Nebraska is 52.4%. So I have no possibility to show you all these 50 states, but as I said, that now with this kind of multivariate analysis with accurate identification of risks, you can do this work, and you can attribute this public health index to each state and each counties and so forth. All right, thank you very much for your attention, and we'll talk next lectures on, as I said, on other topics, including, let's say, prediction, which is a very interesting topic. Bye-bye.